Good morning and welcome to Grand Rounds. Today's speaker is Dr. Juan Olazagasti, fondly known as Dr. O, Pediatric Gastroenterology. Dr. O did his training, his residency training in Miami at Miami Children's Hospital and his fellowship training at Riley in Indianapolis, right?
Correct. Thank you. Good morning. And we are going to be talking about pediatric enteral nutrition. This I borrowed this presentation from the educational deck at the NASPAC and the North American Pediatric Gastroenterology and Nutrition Society. And this is a presentation created by the foundation. And the objectives will include the history of enteral nutrition, indications, delivery modes, components, monitoring, safety, and in our pediatric patients. The second paragraph is mostly another hour of presentation that I'm not going to include this one. This is the program faculty that developed this presentation. Their disclosures. And I don't have any disclosures to bring here today. Talking about the history of enteral nutrition, it started all back from the Greeks and the Egyptians 3,500 years ago, where they used enemas to provide milk, the nutrients of milk, whey, wine, wheat, and also a combination of eggs and brandy.
Turn your volume down just a little bit. Little screech. There you go.
Eggs and brandy. And can you imagine a rectal enema with all this cocktail? Man, you haven't eaten for 1 week. Let's do. Thank you. I get the brandy and the brandy. The brandy is to kind of like give them the sedation after the enema. But anyway, in the 16th century, Capivaccius developed a hollow tube with a bladder that used to insert it into the esophagus to provide nutrition. And this is kind of like the first evidence of a more developed device to provide enteral nutrition, although it's since the 12th century that they were trying to do different ways of giving nutrition to patients. Then in the good 17th century, Van Helmont developed a leather tube with delivery food to the esophagus, and that was a more sophisticated type of tubing. Then John Hunter in the 18th century developed a further more advanced method using a whale bone encasing an eel skin with a combination of jellies, egg, milk, water with mixed with sugar beaten all in there. So these are the very, very primitive type of nutrition provided. In the 20th century, then Einhorn in 1910 developed some type of feeding with a weighted tube to feed the duodenum and jejunum. And then the first hydrolyzed formulas given to dogs were developed by Louis and Abder Halden. These two gentlemen developed this hydrolyzed from protein, pre-digested protein with enzymes and acid. They did not feel that this was safe for humans. But then, by the 1930s, the first protein hydrolysis was used and on surgical patients. And by the 1940s, Stengel and Ravdin developed the first infant formula created with a combination of protein hydrolysis, corn oil, and a combination of dextro, maltose, vitamins, and minerals. And at the end, this was mostly for infants with different nutritional needs, for example, diarrhea, allergies, and GI dysfunction. Then in 1950s, the first plastic tubing was developed, and this was actually polyethylene tubing. The one we use now is actually silicone tubing. And this was done by Fallis and Barron. And Barron, actually, this gentleman developed the actual first feeding pump around the 1950s. Then lately, in 1960, more advancement in the understanding of nutrients and design of liquid formulas were achieved. And the space program got hold on this amino acid formula that has been developed, and they tried to get it to be drank by the astronauts. But can you imagine, this amino acid formula tastes horrible? So that did not fly. That did not fly at all. Next, we're going to talk about the indications of nutrition and intervention. And there's not good evidence in reality to really said that there is the nutrition shorten the stay or improve outcome, even though it's logically to think that it's healing and it helps metabolic processes. In adult studies done in ICU patients, mostly adult studies, in reality, the use of enteral nutrition versus parenteral nutrition did not show any significant difference in the discharge of the patient home or death, and it did not help also to wean them off a ventilatory assistant. But there's no doubt that there was less infections and it was a more cost efficient. When we talk about pediatric enteral nutrition, it's the provision of nutrients via the gastrointestinal tract. Enteral nutrition maintains the integrity of the GI tract and is associated, again, with fewer infections than parenteral nutrition. So who needs enteral nutrition? Well, it's children or adolescents which eat less than 80% of what they need by mouth, and that require extended period of time to eat. So these are the children with sensory problems, chronic illnesses, neurological abnormalities, and any type of chronic illness that will need extra calories. The progressive intervention of nutrition, well, at first we start by mouth. And if the gourd works, let's use it. Enteral nutrition is physiologic. It's, again, less incidence of infection compared to parenteral nutrition. It's cost effective. And we try oral. If the patient cannot eat it by mouth, then we use nasogastric or nasogastric feedings. This is ideally done first by boluses, and if that doesn't work, then we do continuous feedings. If nasogastric feedings are not tolerated, then you use continuous feeding, passing the pylorus through the jejunum or the duodenum. And let's talk about the appetite regulation, which the gut is in the center of a gut-brain energy axis, modulating appetite, metabolism, and digestion. And in the actual gut and brain interactions between meals, for example, we have a stage which lasts a good 90 to 120 minutes. It's called the migrating motor complex. This is a time where our GI tract moves whatever is not necessarily food. It actually is a process where we move fiber, we move whatever cartilage, bacteria. So it sweeps from the stomach down to the small bowel, down to the colon. And this is actually divided in 4 different phases, which the phase 3 is the most important in terms of peak activity in the bowel, and is helped by a peptide called motilin. Motilin stimulates the contraction of the stomach, and it impulses a wave through the small bowel and into the colon. This particular migrating motor complex helps in avoiding a bacteria to migrate from the colon into the small bowel. So it helps to avoid bacterial overgrowth in normal circumstances. Then the reestablishment of appetite comes with the hormones, peptide hormones, orexin and ghrelin. Ghrelin is considered the hunger hormone. And ghrelin is released by the small bowel, and it acts into the hypothalamus by creating the sense of hunger. The other one, ghrelin, also works in the same manner as stimulating hunger, but orexin is involved in the awakening phase of humans, so it keeps us awake. In circumstances where orexin is lacking, the person can develop a type of narcolepsy. So it's a very important peptide hormone. Then in the eating and digestion, then we have gastrin, cholecystokinin, CCK, and pancreatic polypeptide. These are peptide hormones released by our stomach. For example, gastrin is released by our stomach, duodenum, and pancreas, and it stimulates the secretion of acid in the stomach through parietal cells. The other important hormone is CCK, cholecystokinin. As we know, it stimulates contraction of the gallbladder. It stimulates secretion of pancreatic enzymes, and it also has a biofeedback effect on the brainstem by reducing our appetite and in the area postrema of the brainstem. Then at the end, the last mechanism that we have to help digestion is using peptide YY, which is released by the colon and mostly through the entire GI tract, but mostly in the colon. So what it does is actually it's a feedback back into the small bowel to slow down motility and allow foods to be further digested. And the last one that I forgot is leptin. Leptin is released by the adipose tissue, and leptin helps in the satiety, and it helps in the sense of fullness as well. So what causes decreased appetite? But multiple factors. There's emotional factors, there is disease factors, there are drugs like chemotherapy may hamper hunger, and there are other nutritional deficiencies that will affect hunger as well. Conditions like hypothyroidism will decrease gastrointestinal motility and decrease appetite as well. There's also cardiovascular conditions that will decrease perfusion and affect appetite. How do we deliver nutrition when the person cannot eat by mouth or does not eat enough foods? Well, we know about nasogastric tube feedings and transpyloric tube feedings. When we compare gastric versus transpyloric feedings, we first look at what to be fed in the stomach. And for example, in infants, mostly in the neonatal ICU, the orogastric route is very convenient. These babies may stay on infant formula before they can suck and swallow for weeks. And if it's short term, either orogastric or nasogastric, the nasogastric route is convenient. This is mostly kids or children or adolescents that refuse to eat, or they have neurological problems that cannot eat well, deficient in suck and swallow. And in some situations, we use them on continuous feedings at night to supplement. If we need a longer route of providing nutrition, then we use a gastrostomy tube. This is mostly for long-term feedings. It's mostly for patients with congenital anomalies, like tracheoesophageal fistula, esophageal atresia, or chronic failure to thrive. We also use gastrostomy tubes on any type of chronic illness that may be needed to help healing, like, for example, eosinophilic esophagitis with elemental formulas that are not palatable for children, or patients with inflammatory bowel disease. And transpyloric or post-pyloric feedings, these are the nasoduodenal, nasojejunal, gastrojejunal feedings, mostly for congenital abnormalities of the upper GI tract when there is risk for aspiration, severe reflux, or where is any obstruction of the upper GI tract. For example, in cases of superior mesenteric artery syndrome, where you need to bypass the duodenum in order to provide foods further down, distal to the obstruction. Potential complications, mostly mechanical, because we're using a foreign object in our GI tract, so bleeding, pressure, dislodgement with aspiration, pneumothorax, and all these are possible or potential complications, even though, thank God, we don't see them as much. So what is a G-tube? It's a tube placed in the stomach through an opening called stoma. And these are the most common G-tubes that we have. The bottom G-tube, it lacks the connector here with, it can be placed off and on to feed the child or decompress the stomach. And this is the meek, it's a complete tube attached to a balloon at the end. And these are tubes that we place either through the help of our surgeons laparoscopically or by an open procedure, or if in the case of the PEG with percutaneous endoscopic gastrostomy tube, which actually is a tube placed between the surgeons and us, GI. These are mostly temporary tubes that we have to replace after 3 months after the actual abdominal wall is healed and scarred in one single area, which can be then replaced by one of these particular, mostly a button, which is the most that we use in children in our setting. G-tubes can also be placed by interventional radiologists as well. In the case of gastrojejunostomy tube feedings, we bypass the pylorus ideally into the jejunum, and they have a gastric port, a jejunal port, and the benefit of these particular tubes is that you can vent the stomach while you feed the patient into the small bowel. Very convenient when there is gastroparesis, when there is feeding intolerance, or when a child swallows too much air and distends the stomach. So very convenient in those cases with needs for decompression. How do we replace gastrostomy tubes? So this is the actual meek long tube, has a balloon at the end. We de-inflate the balloon, usually carries 5 cc's of water, and it can be replaced in the office setting. This is all after 3 months after placement of the original tube, or after we have put a PEG and this PEG has been removed and placed and replaced by a button G-tube. It has a side balloon port. It can carry up to 10 cc's of water, but we usually use around 5. We use 3 milliliters mostly in babies. Then we have this other type of button tube. It's called either the Bard brand or the Entry-Star brand. It has a fixed non-balloon, and this particular area here can be stretched with an obturator, and this can be replaced depending on the needs. Usually these particular Bard G-tubes last for a good year, and they're very convenient in patients with autism that they tend to pull their tube quite frequent, or children that are very active that need something more sturdy, more durable, that cannot be pulled out. But again, because this particular area does not distend as much as the actual stem, we usually bring these patients and gas them down with the help of anesthesia, and we replace them under some type of sedation or anesthesia because they are painful. And if you try to do this in the office, what happens is because the child gets really scared, they will tense their abdomen, and good luck, because it is painful, it is difficult, and it's a battle. It's horrible, traumatic. So no, We don't do that. I've done it without, but I stopped doing it way back because in fellowship we do a lot of things that you wonder, why did we do that, you know? But in Indiana, we used to replace this on the clinic itself, and I realized, my goodness, this is brutal. So I changed that practice, and I'm sure they don't do that anymore that way over there. In terms of the balloon GJ tubes, it's the same concept of the G tube, except you have the longer J tube going into the small bowel. It has this side port for the balloon. Again, this is not the jejunal port. This is actually the balloon port. You have the gastric port on the side and the jejunal port in the top. It's a longer tube, as I said, and very convenient. Let's talk about enteral nutrition components. The first one is protein. In infant formulas, talking about protein components, you have cow milk-based, soy, casein hydrolysis, and amino acid base. The cow milk-based formulas are the most common. They come for preterms. They come from neonates or preterms. They come for regular infant formulas and even for toddler formulas as well. Then you have the other ones, which are the partially hydrolyzed whey formulas, and these are not considered hypoallergenic, but they're more in between the actual standard cow milk-based formulas and the hydrolysis formulas. And these are the ones that, for example, Total Comfort and Gentle Ease. The soy formulas for specific entities, which I'm going to explain in the next slide, the casein hydrolysis and the amino acids formulas. When we compare these formulas, for example, the cow milk-based, widely available. It's cheap, but I don't think any of them are cheap, really cheap. But they're cheap compared to the more specialized formulas. But oh my goodness, they're all expensive. The soy-based are mostly for vegans, for parents that would like their child to be on a vegan formula. It's used also for galactosemia. Galactosemia is a metabolic disease where the child cannot metabolize galactose, and lactose is actually lactose is digested into galactose and glucose and then absorbed, but these patients are actually intolerable to lactose. So then you use a soy-based formula or a lactose-free cow milk-based formula as well. Then in the case of hereditary lactase deficiency, which is a very rare condition, then you use a lactose-free or soy-based formula. Again, in soy-based, there's no proven help for these formulas for colic or fussiness, and you have to be careful because there's a cross-reaction between the soy protein and cow milk protein. It's up to 40%, this cross-reaction. When the child has a cow milk allergy, then you use a casein hydrolysis formula. These are formulas passed through a quick heat process that breaks the long chain proteins into peptides. It's meant for protein allergy, and there are some studies that suggest some benefits on gastric emptying, so they can be used for severe reflux. And there's some data that also help in atopic disease, babies with severe eczema, or in the cases of parental with severe food allergies and asthma, that can also be used ahead of the game if there's a very high suspicion of any of those in the baby. If the baby's allergic to casein hydrolysis formula, then you use an amino acid formula. In terms of carbohydrates, you can use lactose, sucrose, and glucose polymers. Again, on galactosemia, you want to use a soy-based formula. And I said that you can probably use a lactose-free, but that's incorrect. You use a soy formula, okay? You don't use a lactose-free formula because there may be some lactose in those as well. So you use a soy. In this, one example of soy base is isomil, and there's some formulas that contain extra sugar, sucrose, and these are alimentum and some soy formulas except Prosovi. This was a big marketing tool for some of the formula companies, saying that some of the formulas will add added sugar that wasn't good, but in reality I think that in terms of taste, all the formulas taste terrible. I don't think that adding sugar even will help much the taste as well. And looking at fat content, most formulas, the standard formulas has long-chain triglycerides, medium-chain triglycerides, and some of them that have more medium-chain triglycerides are beneficial in cases of fat malabsorption or lymphatic abnormalities. For example, cystic fibrosis, when you have pancreatic insufficiency, short gut syndrome, where there is an increase in the transit time and decreased surface area of absorption, cholestasis, and protracted diarrhea. Some of the formulas are high in medium-chain triglycerides, and these include alimentum, progestamil, Nutramine is also high in MCT oil, in MCT, Enfocare, and the other ones down here in this particular list. Let's talk about docosahexaenoic acid, DHA and ARA. These are long-chain fatty acids. It's present in breast milk. At first, way back, probably a good 15+ years ago, infant formulas did not have these two components, but at this particular time, most formulas will have, I think all of them will have a DHA and ARA. There's some animal studies that show increased in visual acuity and neurological development, and there's studies supporting this. What is not correct is that the DHA and ARA do not increase intelligence. There's not increase in cognitive development as was reported or marketed in some formulas in the past. There's some additives to the formulas that some of the makers has used, like probiotics and prebiotics. Probiotics may be helpful in some infectious illnesses, mostly diarrheal illnesses. The prebiotics are growth factors that increase or help the growth of good bacteria in the GI tract, mostly the colon. And they use this in many ways as marketing tools as well, but I think that there's nothing wrong with using probiotics and prebiotics in formula. Mostly when you have specific problems like infectious processes as well. Let's talk about standard cow milk-based formula. Again, widely available. It's cheaper than the other formulas, and it comes in lactose-free. It's unflavored, and they all have a mixture of long-chain and medium-chain fats. The semi-elemental formulas, for example, and these are in the range of the Nutramine, Alimentum, and Progestamil type. They're good for malabsorption, short bowel syndrome, inflammatory bowel disease. There are older age group that can benefit from these particular formulas, mostly the peptide, the Peptamen Junior as well. It's meant for milk protein allergy, and it's beneficial, again, for short bowel syndrome and many cases of inflammatory bowel disease as well due to great absorption. The metabolic infant formulas, we have a couple of them are meant for phenylketonuria. Phenylketonuria, it's a metabolic disease where the baby cannot process phenylalanine in the liver, and there are four different type of formulas, four formulas for different type of makers that make these particular formulas for phenylketonuria. For maple syrup urine disease, there's also a formula that they have removed isoleucine, leucine, and valine, which is not tolerated by these particular patients. Maple syrup urine disease is recognized by the urine, some of the secretions, the ear wax smells like maple syrup. There are also carbohydrate-free formulas that they are very helpful in infants, for example, with severe seizures needing ketogenic diet. And there are other modified formulas on fat and minerals depending on other disease states like renal disease. Then we talked about the dye and tripeptide formulas. These are mostly what I mentioned before, the Gentle Ease, the Total Comfort. These are not as extensively hydrolyzed like Nutramium or Alimentum, but there are some reports and studies that shows improved gastric emptying, and they have more MCT oil, so better absorption, better thought. So this is more for children with fussiness, with reflux. So I think that what has happened is that our formula makers have tried to accommodate and cater to our very demanding patient population where nobody wants to tolerate babies with severe reflux or some degree of reflux, even though they're gaining weight and doing well. So I think that a lot of this has come about catering some formulas that may help this particular time of symptoms. I'm not saying that they are beneficial, but it's a slew of formulas out there that is kind of like buying a car when you're going to buy an infant formula. Then we have the elemental pediatric formulas. Again, they're amino acid based. They contain MCT oil. They're meant for allergies and again, ideal for short bowel syndrome. There's an immune formula which has is meant for inflammatory bowel disease. It's called Modular IBD. Not available here in the U.S., but this particular formula has a factor. It's an anti-inflammatory factor, and this is it's called transforming growth factor B2, which is a natural anti-inflammatory factor which is very beneficial for patients with Crohn's. We don't have it available in the U.S. I'm not sure why. It has 25% MCT oil, no fiber, which helps colitis, and it's casein and sucrase based. Then we have other specialty formulas, as I said before, for ketogenic diet and fat transport defects as well. The next group of formulas are blenderized. Blenderized formulas are actually made out of regular foods, and these are actually processed in a blender, which provides very liquidy type of formula. And one of the commercial ones is Complete Pediatric. There's another one called Nutrient. So this is something that for parents that would like something more natural for their children, this is available. Some very motivated parents would like to do that at home, which is always a challenge. And I always recommend them that if they want to do their own blender formula at home, they need to have the coaching of a dietitian, because it's challenging, but at the same time, it requires a lot of skills and expertise. When we look at principles of designing and monitoring pediatric nutrition, we look at, do we need boluses? Do we need continuous feedings? What are the indications to provide feedings? If there's anatomical integrity, if there's functional integrity, or what is the risk of aspiration? Here we have kind of like a delineation of what we do or how we start continuous feedings and bolus feedings. And depending on the child needs and the disease states, we go from a base into our goal calorie intake and fluid intake as well. And we do this sometimes between a day to 3 days, depending on what is how much tolerance. In severely malnourished patients, we have to be more careful because of refeeding syndrome, and so it depends on actually the patient. This is a guideline recommendation, depends on milliliters per kilogram per bolus or milliliter per kilogram per hour in continuous feedings. This is going to be available in the bulletin board if you need this as a reference.
Question.
Yes.
Calories.
Yes, because it's based on what your goal calories are. So you establish your goal calories, and depending on the concentration of the formula is how fast you're going to deliver that particular formula. So it's actually based on what the patient needs in terms of caloric goals, and then you use the rate depending on how much you want to deliver in that particular time frame. So it's kind of the opposite of what you would think, you know. Yes, I agree. And it's easier, I think, in many ways to calculate cc's per kilo than calories per kilo per. I think we're more used to do the cc's per kilo in a way. You see, that's probably why. Then in terms of toleration, on monitoring and tolerance, at first we look for weight, height. We kind of like plot where we start, and then we calculate intake, the calories needed, the protein, the fluid needed, and then we go by tolerance, you know, abdominal GERS, residuals, vomiting, stool output, and be sure that the tube is in the right place. And most of these particular patients, we bring them to the hospital, and we start slowly and advance, and the majority of them need monitoring, mostly in infants or patients with being malnourished, or otherwise what I said before, the fear to develop refeeding syndrome. And once they're established with an amount and a formula and they're tolerating things, any changes can be done as an outpatient, changes of formula, differences or changes in the amount that we give to provide more calories. Is done later on as an outpatient. Most children will need, at least pediatric patients need this gastric or nasojejunal feeding for at least a couple of weeks. The reality is that because it's something foreign, it's very difficult to keep a child with a tube in the nose in the GI tract. Ideally, we like to do it for a longer period of time. Babies, we tend to keep them on longer than the couple of weeks, probably because they're babies, but if they have, parents that can keep that tube down without being pulled, then we like to keep it a little bit longer as well. In terms of monitoring, again, in the cases of diarrhea, abdominal pain, we kind of like modify delivery rate, we can change the formula, we can use some medication to help diarrhea, we can use benefiber to bind more water and help the diarrhea, or we can change the formula to a more elemental formula. In cases of vomiting, positioning the patient with an elevated head, avoid giving the formula too cold or too warm, just room temperature, that's the way it should be given. And if that's the case, in the cases of vomiting, then transpyloric or transjejunal feedings are ideal. We don't see a lot of hyperglycemia in our patients unless they have diabetes, but in some situations, if there's hyperglycememia, we can use simple sugars, formula based on simple sugars to help sugar absorption, and if the case comes, we can always use insulin to help glycemia. In situations where there is normal bowel function and normal fluid requirements, we use a formula that is usually whole protein, long-chain triglycerides, and they're lactose-free. If we're going to try oral feedings, these formulas are more palatable for our patients. If we try tube feedings, then we have these other choices of formulas like complete pediatric, Jevity, osmolite, and they're not as palatable, of course. If there is a volume intolerance, then you can use concentrated formulas. If you need to provide a formula that is easier absorbed, or if there's fluids restriction, then you use a higher calorie formula, like a 1.5 calorie per cc that provides 375 calories per 8 ounces, or a 2 calorie per cc formula like Nutrient or 2Cal. And these particular 2 calories per milliliter, these 2 cal formulas are not very commonly used by us in pediatrics. If there is impaired digestion, then you use a peptide base, and easier to absorb protein. And in the cases of also a malabsorption, then you use a hydrolyzed protein with a mix of MCT and long-chain triglycerides. And these particular pediatric formulas and these particular infant formulas. And you can always use also peptamine 1.5. Peptamine comes unflavored, and it's very convenient when you want to reduce osmotic load in the GI tract for tolerance. When we talk about abnormal function with allergy, then you use an amino acid-based formula like Elecare, Infant Elecare, Neocate, Nutramian AA, Pure Amino, Tolerex. In the case of fat malabsorption, again, you use a formula that has high MCT oil, like Portogen, Amphoport, Progestamil, or Tolerex, or Vital. These are great for chylothorax, situation where you have chylothorax, where you have pancreatitis, and when you have, for example, chylosasitis because of damage of the thoracic duct. So how to add protein, carbohydrates, or fat to our formulas, and in addition to what we do with our patients to provide what they need. Beneprotein is one of the available powder proteins that can be given. These are whey and soy protein isolates. They cannot be used for protein allergy. It's 6 grams of protein per scoop of powder. This is very beneficial in cases, for example, we have some kids with cerebral palsy, which they may be 5 years old, but they just need 2 cans of Pediasure, let's say, in a day. And aside from providing more protein needs, we can use Benefiber. You have to also keep in mind that if you're giving 2 cans of formula, you may need to add more free water in order to attain what you need in terms of fluids. And you may need to add more vitamins and minerals as well. So the dietitian usually helps with this, but the protein is itself something that we can calculate, and we can actually use Beneprotein. Very, very helpful. There are amino acid modules as well available. I'm not familiar with any brand used in the market. In terms of carbohydrates, polycose powder is very, very easy to use, blends easily, doesn't have much sweetness in it. It's low osmolality, and it's very, very good alternative. It has 8 calories per teaspoon. That's polycose powder. Then in cornstarch, it's a very cheap way of thickening feedings. It's great for the use of hypoglycemia and dumping syndrome. You have to be careful because it tends to cake, so it's not good for continuous feedings. But it's cheap and it's readily available. Great for dumping syndrome, and you have to give it during boluses. You cannot use it on continuous feedings. We do not use corn syrup, dextrose, fructose, or sugar, so we don't recommend to add sugar to our kids' formula. In terms of fat, corn oil is cheap, available, and you have to use it on boluses. You cannot use it on continuous feeding because it separates with the formula. MCT oil is again, used for bile acid problems or lack of lipase, anything related to cholestatic problems. Does not have essential fatty acids, so you have to add some essential fatty acid in long-chain oils. It's expensive. The next one is microlipid. It's not a high calorie, but it's very beneficial for continuous feeding because it has it's an emulsion, so it blends very well, and it's very convenient. It's safflower oil based. And MCT Procal is a powder type of MCT oil available. Duocal is great. We use it a lot in our outpatient settings. It blends very well. You can add it to any food, any particular liquid, and it's cornstarch and refined vegetable oils plus MCT oil. It has no protein, so you have to keep that in mind. And again, it has 25 calories for every scoop of powder. The last type of formulas is the clear liquids. These are kind of like a fruit-like taste to provide whey protein to children that do not like dairy-based, milk type of formulas. It really does not taste like fruit juice, but I think that it's tolerable and liked by many of our children, and it's a great alternative to provide calories. And this is basically oral. So in terms of how we manage or how we evaluate tolerance, so there's gastric residual volumes assessment, and this is there's no standard practices on how, when, or what to consider high volume gastric residual, and we have to be really careful because in many situations, if we get too anal checking residuals, we may not give enough calories to these particular children. So in other ways, if they're not vomiting or gagging or having intolerance, just in most situations on patients that are otherwise tolerating their feeds, we don't recommend to check gastric residuals, except if they are acutely ill and on continuous feedings. For example, you could check residuals every 4 hours, and this is not it's not good evidence based information, but this is some suggestions that you can do. For example, on continuous feeding, you check them the hourly the volume on continuous rate, and if the actual residual is at least greater than the milliliter per hour that you're providing in that particular rate, then you have to either stop the feedings or wait an hour. And again, how long to wait is always a challenge. I usually think that more than an hour is probably not needed, and you recheck them again. In bolus feedings, you check the amount of residuals right before the next bolus, and if it's more than half of what you gave in the prior feeding, you may need to hold it for a little bit as well. But again, we have to be careful not to go crazy with residuals, because otherwise it hampers the amount of calories that we give if we check that all the time. In safetiness, let's talk about refeeding syndrome. Refeeding syndrome is described as the metabolic and clinical changes that occur during nutritional support of a malnourished patient. This usually happens in 3-4 days after we start feedings. And the signs and symptoms are weakness, muscle pain, ataxia, paresthesia, confusion, arrhythmia, seizures, and the hallmark of refeeding syndrome is phosphorus depletion, but not to say that potassium, magnesium, and calcium are also involved. The risk factors include severe malnutrition, anorexia nervosa, patients with obesity, even patients with obese that has lost a lot of weight are to be careful with refeeding syndrome. Malnutrition on prolonged IV fluids, and the actual identifier for our pediatric patients are children with less than 80% of their ideal body weight by calculated body weight, okay? Less than 80%. So when the patient is malnourished, there is a state of starvation, and there is catabolism. And essentially, the body is breaking everything to provide sugar to our brain and muscles. So there's glycogenolysis, gluconeogenesis, and there's protein catabolism. There is also, to some degree, depletion of salt, depletion of water. So when you feed that particular child, there is a switch from catabolism to anabolism, and the sugar kicks in, carbohydrates, fluids, salt, nutrients, but mostly carbohydrate, sugar trigger the release of insulin, and insulin then brings and increases synthesis of protein and glycogen. And what happens is that there is a shift of phosphorus, potassium, magnesium inside the cell. And not only that, there is also thiamine utilization, and what you end up is depletion of all these particular electrolytes. And then that causes the same all these slew of side effects and symptoms that I described: weakness, muscle pain, ataxia, paresthesia, confusion, arrhythmias, seizures, and sometimes even death. In the case of phosphorus, we need, as we increase use of utilization of sugar into the cell, the mitochondria will produce more ATP, and it uses the phosphorus. So it not only gets the blood depletion of phosphorus, but also the intracellular, we are depleted of phosphorus as well. That, in addition to muscle atrophy that can happen during malnutrition, which also cause problems with ventricular dysrhythmias and even sudden death. So potassium and magnesium, again, potassium is driven inside the cell. Potassium depletion will cause QTC prolongation, and possible cardiac arrest or dysrhythmias. In the case of magnesium, cardiac and neuromuscular dysfunction, including seizures. So what to do? You first hydrate the patient well and try to replenish electrolytes. And then if you're ready to start feeding, you start with at least half of the goals of feeding, and you do that over the next 72 hours. You increase slowly every day by 10 to 25%, depending on how the electrolytes look. You have to check all these electrolytes on a daily basis, and sometimes you have to provide oral phosphorus or potassium in K-phos, for example. That's a product available, or IV if needed. In the cases of severe electrolyte disruption, you have to transfer the patient to the ICU for close monitoring. So in summary, our malnourished patients have altered metabolism. They are depleted intracellularly of all these electrolytes, phosphorus, potassium, and magnesium. And the initial management should focus on correction first of fluids and electrolytes, and then on calories. Again, careful with aggressive refeeding because it can cause deadly side effects and problems. So you have to anticipate, you have to monitor, and you have to actually go slowly but surely. And important to know that protein is not part of it's not a trigger of refeeding syndrome, so you don't necessarily have to limit protein in these particular patients. So this is the end of the lecture, and I'm open for any questions.
Any questions in the room? Juan, we look for refeeding syndrome all the time in anorexics and the older children. In the little ones, you know, the 2-month-old who's failing to thrive, it seems like we're starting to check it now. Historically, I just never did that, never thought of it. Right. Do you have a comment on that? Like, should we be paying attention to that in a 2-month-old who comes in, or a 6-week-old that's, you know, at birth weight?
I agree, and in reality, the experience is that I think that if they would truly develop refeeding syndrome, we would have seen it multiple times already, because we've been doing this forever. But I don't know the reason why they don't actually go into refeeding syndrome compared to other patient population. But we have not checked that, and I think to some degree it won't be bad practice to at least check a set of electrolytes just as a baseline and one more time. because they are at risk in reality, mostly the ones that are extremely malnourished, when you see that there is depletion of subcutaneous fat, and they're really at potential risk. But yes, that's absolutely correct. We have never seen it in babies. Otherwise, I'm sure we would have. Yes, Emma.
Okay. On behalf of the medical students in the room, I thought it would be nice to have a discussion about outpatient when we're trying to switch infant formulas because of some perceived problem tolerating the current formula. Could you share your expertise and advice regarding what the primary care should be thinking about, and how long do we wait? What type of advice should we be giving the parents? I also have kind of a resident level question if time permits after that. Correct.
Well, that's a good question. And, you know, in our practice as pediatric gastroenterologists, the patient has already been, the baby, or the patient has already, mostly the babies, have been on several formulas already. But I think that in the standard baby that, for whatever reason, is not breastfed, and we're going to use an infant formula, we have to start with the basic cow milk-based formula. And if there's no medical contraindication for that. And I think that what drives a lot of our changes in formula is parental anxiety. It's the intolerance of parents for the gassy baby, the reflux babies. But I do think that we should be more judicious in terms of when to switch formulas, because in reality, most of the time, at least in my observations, it's not a formula problem. It's just a functional issue with the baby, which there are some factors with gas, there's some factor with reflux. But how often, it all depends on how well the child is doing. If the baby is doing fine and growing, I think that's number one point for the parents. Where, you know, the baby is growing, he's having reflux, but if there is no other concerns, then I would try to reassure if you can. If you can't, then you may be able to switch to other formulas after probably a couple of weeks of just reassuring the parents. And in that particular case, if there is no signs of blood in the stools or any type of vomiting, projectile vomiting, then, you know, you could try to use some of these other formulas that are in between what is the standard formula and the hydrolysis formula. And mostly to give the parents an alternative to C tolerance. I think that because the way that our parents see the baby's symptoms, we are pushed and we cater to a lot of their pressure. And that is a big deal. But at the same time, we're in the customer. we need to, in a way, balance our practice with what the parents' perceptions are, mostly in this age that we take so much of the parents' weight or opinion in account. So we have to kind of like give them but if there's blood in the stools, then you need to go use a hypoallergenic formula like Nutramium or Alimentum. There's no doubt about it. If there is any chronic diarrhea or suggestion of malabsorption, then you check your stools for malabsorption, and in between you can still use some formula which has high MCT oil and try to help that as well while you do your workup. If there is any question about allergy, you can always do a lactoferrin on the baby on the formula, or you can do a calprotectin, or if it's breastfed, calprotectin. But I think that any type of change into a hydrolysis formula or elemental formula like the Neocate or the Elecare or amino acid, there should be some type of documentation of intolerance in order for us to switch. because I think we're too prompt to just convince, help the parents and just satisfy the parents' needs and just switch them. And I think that at the end, I don't think it helps anything. It's very costly, and most of our babies, half of them probably, are on WIC. So it's really a big burden for our Medicaid program as well.
Okay. Thanks. And I think I heard you say kind of in there that if we're changing formulas, we really ought to try to give the new formula maybe 2 weeks, something like that.
At least 2 weeks. At least 2 weeks after reassurance that the baby is growing, is gaining, and this will be my as a primary. And I always go to the parents and try to tell them this is not a formula problem. It's not necessarily an allergy. So I try to reassure them in the case that it's not an allergy, that it's just reflux, and explain to them why the baby is refluxing and why the baby may be gassy. That is something that will get better as they get older, close to the 6 months of age. So when their GI tract function improves, so yes, I would say for primary, I would say a couple of weeks at least after reassurance, if you don't feel that there is a need to change.
I think we're out of time, actually. So thank you very much, Doctor.
Thank you.
If you're still on the line and you had a question, sorry we didn't get a chance to open them up. If you email me at outreach@carilionclinic.org, I'd be happy to get them to Dr. O to see if he can answer them for you. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much.